out there. All right, so BPD itself. You've all seen the DSM criteria. This is nothing new to you. All right, how helpful do you find that list of criteria in actually diagnosing borderline personality disorder? So we have this list, and because you only need 5 out of 9, you get 256 permutations. That's kind of, you could put 256 patients with BPD in a room and every single one of them would present with their own unique cluster of symptoms, right? Not overly helpful. So you developed more of an analytical approach. You want to talk about that?
Yeah, sure. Well, the previous list of symptoms is just kind of like a scattergun of what the most common sort of obvious things are, and that's fine. But I just found I had to memorise this list of 9 and always work through this checklist. So I found it more helpful to come up with the sort of ideological ideas. So in italics, this runs over 2 pages, but in italics are those diagnostic criteria we saw before. But from an etiological point of view, most people with BPD have a biological predisposition whereby they've got a sensitive temperament or a hypersensitive temperament. Okay, so that's very unusual not to see that. Okay, if you don't see that, it's probably going to be complex PTSD that you're dealing with. Okay, and there is some indication of a genetic predisposition, but it's very hard to untangle that because if mum was a borderline, are you borderline because of the environment or because of the genetics? So I don't know that that's really well established. Then we have, these are the typical early childhood experiences, unmet childhood needs, in particular sort of an invalidating environment. Yep. Early trauma is common, that can predispose to complex PTSD. We're keeping referring to it, not really getting into it today.
Not so much.
Yeah. Perceived rejection, again, that's a sort of invalidation experience, invalidation of emotional experiences. And this sort of parental mismatch in temperament. So some parents might have a hypersensitive child, but they're well attuned to that and they can provide the appropriate soothing and nurturing and so forth. And others are like, just harden up, just get on with it, invalidation. And that just comes from the difference in parental temperament. All right, so you get this interplay between nature and nurture, and this is what gives you your 3, I've called these the first 3 criteria, but they're not the first 3 numerical criteria in the official DSM criteria. So fear of abandonment, and this is what the DSM criteria is, manifests as frantic efforts to avoid abandonment. Yep. Fluctuating sense of self-identity, so they're sort of trapped in this chronic adolescence. As adolescents, people shift who they are, what they think of themselves, on a month-by-month basis, or
the chameleon effect.
Yeah. Yeah.
They will change who they are and how they present themselves based on which social group they're hanging out with that day, or when they're in front of their parents, or when they're in front of their grandparents, and so you see this kind of real fluidity. But at the end of the day, you go, well, who are you now?
Yeah.
I don't know.
They don't have an established sense of who they are, so they tend to absorb whatever favourable influences or even unfavourable influences are around them. Yep. And chronic emptiness. So that's 3 of the 9 criteria. They don't necessarily have all of those things going on, but often they do. In fact, mostly they do.
Well, I mean, if kind of those ones are missing, then you probably don't have BPD. So kind of even within the 9 criteria, remember how with the depression criteria, you've got 9, but it says you've got to have the first 2, you've got to have low mood for 2 weeks, and you've got to have the anhedonia. With BPD, I'd kind of be leaning towards the same sort of thing with this. If you're missing those 3, then maybe we're not actually talking about BPD. Maybe it is more kind of complex trauma or something a little bit different.
Okay, and then these are the DSM criteria, and I kind of consider these the reactive features. So because you've got this sort of chaos going on, your mood's unstable, you tend to be impulsive in various situations, prone to anger, suicidal behaviour or threats, and possibly stress-related paranoia or disassociation. So they're sort of nested in the. But of course, you can get tons of other stuff. So patients with BPD, not only do they cut, but they might drink or be sexually promiscuous, or God, anything, reckless driving, whatever they do when they're ticked off. Yeah. Okay. And often people have their go-tos, right? And if it's alcohol, you tend to get labelled as you've got a substance use problem, okay? Because you notice that substance use isn't anywhere here. Okay, but it certainly happens a lot in BPD. Okay, so yes, and here's some other features. And because of all this, so you're in this relationship, your unstable sense of self, you tend to sort of blow up because if your abandonment fears, tends to lead to unstable interpersonal relationships, and that feeds back into the fear of abandonment. So I think that sort of formulation makes a lot more sense than 9 sort of random symptoms.
What do you think?
Comes up for me that's a little interesting is that I've had a lot of exposure to ADHD, and some of this stuff is like, you're like, oh, that's a lot of that. Can
There's-
also look a bit like ADHD to me sometimes.
Yeah, I agree. There's about a 34 or 38% overlap between ADHD and BPD. So it's very common to see
Yeah.
both in the same individual.
Yeah. Tricky to tease that
Yeah.
out sometimes.
It is. You know, it's the, I mean, the inability to concentrate is the sort of hallmark feature in adult ADHD.
Right, yeah.
But often people can be in such a tears that they can look like that.
Yes.
Right. The way to tell is give them a stimulant trial, and if all of a sudden everything got resolved,
Right, yes,
okay,
yes.
well it was ADHD.
Interesting.
Yeah.
Very interesting.
Yeah. Whereas kind of, I mean, they can be quite, have a lot of difficulty concentrating in the context of trauma as well, particularly if they've got kind of overactive limbic system and their amygdala is firing off at every kind of stiff breeze sort of thing.
Yes.
And so again, it's kind of hard to try and tease this out, which is part of why we've made our group multi-diagnostic. We're targeting the symptoms,
Yeah.
not the label. Giving patients the diagnosis is actually more validating for them, because once they have a diagnosis, then we can kind of direct towards treatment.
Well, I think I'll just jump in on that. I think the reason that a diagnosis is helpful to people is people just feel like they're trapped in chaos and there's something profoundly wrong with them and they don't know what it is. And once they get a diagnosis, it's like, oh, okay, well, I'm not the only person in this boat. There's all these resources now that I can read up about or access or whatever. So it tends to order their chaos. And that's a thing that comes up a bit, I think, throughout our talk, is that BPD is a high chaos state, right? And anything you can do to help people order their chaos is going to be of great help to them.